Bismillahirrahmanirrahim. Assalamu alaikum. Viewers, today I am here with an important topic on pilonidal sinus, also known as pilonidal disease, G-bottom or driver's bottom. Before I proceed to my today's lecture, I request you to subscribe my channel if you have not subscribed. And innovation in today's lecture is that it includes description along with surgical procedures. I have tried my level best to describe the management of pilonidal sinus disease along with surgical procedure. Viewers, I am Dr. Muhammad Salim Iqbal, Assistant Professor of Surgery, Deputy Controller of Examination, Faisalabad Medical University, Faisalabad, Certified in Medical Teaching from University of Health Sciences, Lahore, Research and Clinical Coordinator to Vice Chancellor, Faisalabad Medical University, Faisalabad, Spokesman, Faisalabad Medical University, Faisalabad, Production Editor and Focal Person of Prime Minister Delivery Unit, Faisalabad Medical University, Faisalabad. I dedicate my lectures to my colleagues and juniors who participated in today's surgical procedure. I am always motivated from my colleagues and juniors. A beautiful saying of Albert Einstein is that you only fail when you stop trying. So keep on trying new things in your life. Inshallah, one day will come when you will be successful and you will reach at the top. Pilonidal sinus is derived from pilus mean hair, nidus mean nest. It is of infective origin and occurs in sacral region between the buttocks. It is epithelial line tract situated short distance behind the anus, containing hairs and unhealthy diseased granulation tissue. It is due to penetration of hairs through skin into subcutaneous tissue. It forms granuloma, that is unhealthy granulation tissue in deeper planes. Types of hair, force of hair insertion into subcutaneous tissue, and vulnerability of skin are three factors that cause pilonidal sinus. Numbers of hairs collected, acuteness of root end of hairs, type of hairs, tuft or silky, shape of hairs that may be straight or curled, scaliness of hairs are deciding features of hairs. Cut hairs from above descend into cleft and stay there to get buried behind into pilonidal sinus. Depth, narrowness, friction movements in the natal cleft, soft or macerated skin with erosions, splits, wide skin pores, wounds, presence of moisture and sweat are other factors that contribute to the development of pilonidal sinus. Pathology: hair penetrates the skin, then it leads to dermatitis that causes infection and pustule formation, which leads to sinus formation. Then hair gets sucked into the sinus by negative pressure in the area. Further irritation and granulation tissue formation takes place. This causes formation of pus and it results in multiple discharging sinuses. Clinical features: discharge, which can be either serosanguinous or purulent, discomfort and pain, primary sinus and on either side of midline secondary sinuses. Tufts of hair may be seen in opening of sinus. Presentation may be as acute exacerbation, that is abscess formation or recurrent infection, or as a chronic one. Complications: chronic pilonidal sinus can cause occasionally sacral osteomyelitis, necrotizing fasciitis and rarely meningitis. It is not a life-threatening condition, but often it can be a morbid disease because of high recurrence rate. How we treat pilonidal sinus? In acute phase, initially drainage of abscess is done along with antibiotic cover, and later definitive treatment is carried out. Definitive treatments are excision and primary closure, excision and skin grafting, which is reported to have high recurrence rate. Then excision with Z-plasties, it has a good result. Excision with multiple Z-plasties, Keridakis excision through a semilateral incision and lateralized suturing of wound away from the midline gives good results. It is depicted in snapshot. The next options are excision with closure using Limberg's rhomboid buttock flaps, single or double rhomboid flaps. It has good result. Then VY gluteal advancement flaps. Bascom technique is another option for pilonidal sinus. In this technique, a small lateral incision or multiple small lateral incisions 2 to 4 mm size sinus is approached and pus is drained. Hairs are removed with only minimal excision of sinus. Then lateral small wounds are either sutured or left open for spontaneous healing. Briefly about recurrent pilonidal sinus. Three possibilities account for this disappointment. Part of sinus complex has been overlooked at the primary operation. New hairs enter into the skin or the scar, and there is persistence of midline wound caused by shearing forces and scarring. In this situation, revisional surgery may include re-excision followed by wound closure and obliteration of natal cleft either by myocutaneous rotational buttocks flap or cleft closure, that is Bascom's technique. Now briefly about Limberg's flap. Limberg flap procedure is a safe choice for surgical treatment of sacrococcygeal recurrent pilonidal sinus disease due to its low complication rate, short strength of hospital stay, early return to work, low visual analog score, high patient satisfaction, and shorter complete healing duration. I will briefly describe the steps of surgical procedure. Steps are: patient is placed in prone position, pre-operative hair shaving is done, and 1 gram of ceftriaxone intravenously is given before shifting to theatre. Then buttocks are retracted using adhesive tape to obtain a better visualization of operative feet. After skin preparation, a rhombic area is marked that includes both midline pits and lateral sinus extensions. Long axis of rhomboid was in midline and its shape is determined by angles of 60° at A and C and 120° at B and D. First, line A and C was drawn and its length was measured. C should be adjacent to perianal skin and A was placed so that all the diseased tissue includes in the excision. The line BD transected the midpoint of AC at right angle and was 60% of the length of AC. Flap was planned so that DE was direct continuation of line BD and of equal length to incision BA, to which it was sutured after rotation. EF was parallel to DC and of equal length. After rotation, it was sutured to AD. This is marking for Limberg flap as I have described. Skin subcutaneous fat is removed. Flap is raised so that included skin, subcutaneous fat and fascia overlying gluteus maximus is mobilized, and it was then rotated over the midline rhomboid defect, and defect this created was closed in linear fashion. Drain is placed. Deep absorbable sutures to include fascia and fat were placed over the vacuum drain, and then finally the skin was closed with interrupted sutures. Then antiseptic dressing is done. These are a snapshot of today's procedure. This is marking for Limberg flap surgery, intraoperative snapshots, and then this is the post-operative outcome. Now we will shift to detailed operative procedure. At the end, I am very thankful to you for your valuable time. I hope you have enjoyed my today's lecture along with surgical procedure. If you have any question, you can find me on my Facebook account, on my LinkedIn account, Twitter, Instagram, YouTube, or ResearchGate. I wish you all the best. Take care of yourself, follow Corona SOPs, and stay blessed. Allah Hafiz.